So now if you look at assessment, the key questions you have to answer is it really diabetes insipidus or not? If it is diabetes insipidus, it is cranial or nephrogenic, central or nephrogenic, and finally, what's the cause in that regard? So diagnosis, most important is to make sure that this is DI. Once you diagnose DI, you are treating for life. You have a commitment to make the correct underlying diagnosis. So most patients who come to you with polyuria will not be DI. So you have to be very careful in selecting those patients who really are DI and then do the workup. Otherwise, you will be doing unnecessary workup in most cases. So how does DI present to you with? So of course, we know that DI, of course, AVP is less. You will have polyuria. You will become dehydrated, and dehydration may be there, and fever. This is classical presentation in early childhood. At that point of time, individuals are not taking water. Hypernatremia is a rare phenomena unless the thirst is affected in young children or post-operative. These are the causes in which you will have hypernatremia and cell shrinkage. The most common manifestation is increased thirst, which everybody will give you, and typical feature will be that if you are drinking a lot of water, there will be growth failure. But some children I have seen who are drinking a lot of formula feeds, they will develop obesity. So early onset of obesity may be the first manifestation of a DI. This may also be part of a hypothalamic lesion causing more thirst. Urine output, of course, will be more. If you have long-standing polyuria, you may develop hydroureteronephrosis in areas where the fluoride content, or let's say any toxicity is more in water, you will develop fluorosis because you're drinking so much water in that perspective. This is something which is important. So pointers, of course, are polyuria, but polyuria is a very, very common complaint. So you have to ask specifically for nighttime awakening, whether there is nocturia, whether there is actual dehydration, failure to thrive, unexplained fever. Often they will give you a history that whenever he has diarrhea, he really requires IV fluids. This basically means that he has already dehydrated and then diarrhea will cause a problem. Seizures may happen late, and classical history which always I get is they will prefer licking ice and taking cold water because that quenches the thirst quickly, which we discussed in the last class. And hypernatremia is rare in that perspective. Very simple, diabetes insipidus is concentrated blood with dilute urine. So you need to have concentrated serum, which you can identify with sodium more than 146, and dilute urine, which means urine osmolarity less than 600. Now there's debate 600, 800, but if you want to have true DI, it is less than 300. I think there's no confusion there. And specific gravity less than 1010. You have to exclude, of course, renal failure and renal tubular acidosis as possible differentials in that regards. So polyuria can be because of increased osmotic load or a problem in concentration. Osmotic load may be because of diabetes, the most common cause, or mannitol use. Saline and fluid, particularly post-operative, if somebody is giving lot of saline, you will develop that scenario. Concentration problem can be tubulopathy because of RTA, Barter's and Gitelman. And one major cause of polyuria there is hypokalemia. The second is diabetes insipidus, which is causing central or nephrogenic, which we have discussed already. So how do you say this is polyuria? You need to have a urine output measurement. So remember, more than 2 liters per meter square per day. So always remember meter square is a much better way, and 5 ml per kg per hour. Now remember, older the child, lesser would be the per ml per kg area, but normally 5 will be good enough till around 5 years. So this child, as you mentioned, was taking around 5 liters per day, and he was how many kgs? It was 14.90. 40. So he's taking a huge amount. If you think of per ml per kg per day, it will be huge amount. He's taking around 10 ml, 15 ml per kg per hour, which is a significant polyuria. There's no confusion there. Now, workup, of course, is always, so if you're in doubt, I would say ask the parents to record the urine output, and it is difficult sometimes to record the intake. Normally, intake output should be same. So you can ask them to basically take the same bottle and see how many bottles he is drinking, how much milk, how much tea and everything. Or if they can collect urine also, it's important. The message is water deprivation test should be done in a very planned fashion. You cannot just immediately rush and say, okay, come tomorrow morning, we'll do the test. Make sure you need, because it's a very, very painful procedure. If you think of any other test, growth hormone, maybe you are requiring multiple samples, but here you are keeping them in the ICU or a high dependency unit. You are stopping water. Somebody who's really thirsty, you're stopping water, taking so many samples. So it has to be done only once. And the priority is to have a good test rather than quickly finish it off. So that's what I will come to a bit later. Workup should include, of course, urine RM, glucose, blood gas, everything should be excluded, creatinine, calcium, potassium, and screening you can do using an early morning sample. Be a bit cautious. If the child has this level of polyuria, generally we don't really say that stop everything from evening. Now, if he's very thirsty, he can have, but if he is able to do it without that, you can check an early morning sample. The peak concentration of urine should be there in the morning. So the highest level of urinary osmolality or a urinary sodium will be in the morning, which will give you an idea in that perspective. Now, always look for things which can worsen the thing, like drugs, obstructive symptoms, rickets, acidotic breathing. These things will become important. Now, how do you assess? One, of course, is osmolality. And osmolality, of course, means how many moles are there in that regards. And how do you measure? How do these machines measure osmolality? So what does it mean? That increasing in the temperature will decrease. So if you increase the osmolality, the freezing point will be dipped down. And this technique is used by a lot of people who, if you have seen, a lot of people make kulfi or they make ice by putting on salt and everything. That's by the osmolar changes, they change the freezing point. So this is the same method. So this much osmol should depress the freezing point by this much. This is the standard method of measuring osmolality. But many centers do not have osmolality. So I would say the most important thing is to look at the sodium level. They will do a lot of calculated ones, glucose and BUN, but if you look at simple sodium, that will give you a very good idea in that perspective. And for urine, you can also look at sodium. For urine, you have to make it 4 times the sodium. That will give you a rough idea in terms of osmolality. Serum sodium more than 146 is roughly equivalent to plasma osmolality of 300 and a maximum concentration which should happen with AVP. Some centers use AVP, this specific gravity measurement. So this ideal machine is like a dip, one which can do the specific gravity, but the refractometer is also reasonable idea. The strips are not good to assess in terms of the specific gravity. So I would prefer the refractometer, which can give you a good idea. This we already discussed, that you expect that as you compare osmolality with specific gravity. So I'm putting this because some centers may not have osmolality easily available. So 1005 is something which is equivalent to roughly 100. 1010 is roughly equivalent to 300. And if you go to 1015, it becomes around 600. So your classical figures of 300 and 600 becomes 1010 and 1015. Mostly when you talk about true DI, it will be like total water, 1005. That's what we will identify in that perspective. And as the concentration increases, of course, the osmolality and specific gravity will match on that. Remember, this is not a perfect correlation. You can't just say that every time this is equivalent. But if you combine urinary sodium, make it 4 times, and you add specific gravity, you will get a good enough idea in that regards. So first of all, you confirm polyuria, do the basic workup, creatinine, potassium, calcium, blood gas, urine RM and glucose, and look at urinary osmolality when the plasma osmolality is more than 300 or sodium is more than 146. In this scenario, if your urine is more than 600, I am pretty confident that this is not DI, at least to a significant extent. Some people say 800, but that is becoming too liberal in that perspective. If it's less than 300, this is true, complete DI. In that regard, 300 to 600 will be partial DI. Now, all you have to do is to look at the AVP response. Now, which preparation to use? You can use the desmopressin, you can use a subcutaneous AVP. I would always prefer the subcutaneous because I have seen problems with giving AVP because single dose may also cause problems in terms of long-term response. So a single injection of AVP will give you the response. If the response is present, which we define as a rise in osmolality by more than 50% over baseline, that is suggestive of central DI. There are as many protocols as centers in this part. So be careful, whatever you're using, you stick to the same protocol. Usually, it is a very, very clear-cut test. Once you give vasopressin, the color of urine will change from complete white to yellow, and you will not be any confusion. So don't be too much confused that some books say this, some books say that. It won't make much of a difference. So urine output more than 2 liters per meter square, it becomes important. So we have a 3-year-old boy with failure to thrive with polyuria and lethargy. Height is 81, weight is 8 kg. What do you think about the growth pattern? Hmm?
She also expect weight. This is like 1.5 years.
So he is very, and weight is much less. So everybody thought this could be DI. Urinary osmolality was low. Water deprivation test was done, which confirmed DI and confirmed nephrogenic diabetes insipidus. So do you agree with this, or you want to do something else?
All the other causes of polyuria that because they will like that. But sometimes in the long-standing cases of DI, it may manifest as a picture of nephrogenic DI because of this.
So lack of response to AVP. Now, if we say response to AVP is a sure shot sign of DI. Lack of response is not a sign of central. It does not exclude central DI or other forms because long-standing, if you have a lot of polyuria, the medullary concentration gradient will be washed off. So they will not respond to that. But the bigger question is, why does he have such failure to thrive? So you have to think of whether everything has been done or not beforehand, which you rightly said. So blood gas, this is something which is very important. So this is more behaving like RTA to me, and there was rickets and there was acidosis. So don't do a water deprivation test unless you have excluded these scenarios. 3-month-old girl with dehydration and dovey skin, sodium is 162, osmolality is low. Advise water deprivation test. How will you conduct the test?
In this scenario, since the sodium is very high, sir, we should not go for water deprivation test.
Doesn't need. The child is already dehydrated. The water deprivation test has been done by the nature. Somebody who is hypoglycemic, somebody who is hyponatremic, somebody who is in shock, you don't want to give a ACTH further because already the body has done a ACTH test on him. This case already is dehydrated. If you do a water deprivation, it will be dangerous. Seizures may develop, so never do a water deprivation in that regard. So if your sodium is more than 145, you don't need to do a water deprivation test. Okay, so water deprivation test basically should be done if your urinary osmolality is less, so urine is dilute and plasma is also dilute. If plasma is concentrated, there is no need. If urine is concentrated, no need because you have excluded DI. Prerequisite is normal renal function, glucose, blood gas, electrolyte. This I have already discussed. The role is mainly to diagnose, rule in or rule out DI and to classify DI if it is there. It should be avoided if your osmolality is more than 600. Your work is done. Why do you need to do that? It excludes DI. If sodium is more than 146, do a AVP response. Don't go for, like if this boy, his sodium was 146, we would have done directly a AVP response test. But sodium was 141. So that is why water deprivation test will be needed. Sodium less than 130, extremely unlikely to have DI. DI will cause normal sodium, but not low sodium. So this is most likely a compulsive water drinking, quote unquote, psychogenic polydipsia is what we consider. So water deprivation test has to be done in the hospital. If somebody has this level of polyuria, I'll be very cautious. So you may say, okay, they may not drink, but they may drink if they are becoming too dehydrated because there have been episodes of seizures if we avoid that. Baseline weight should be taken and then you say 5%, which is your target for weight loss. So somebody is 10 kg, you say, okay, 9.5 kg is what I want to as a target weight loss. Check urinary and plasma osmolality and sodium. Lab coordination is important because Often labs will take hours for report to come. So you have to tell them, okay, I want it immediately within half an hour to get the result, because otherwise there will be a lag phase and you will be in a big trouble. Monitoring should include urine output, weight and hydration. Hourly urine and plasma osmolality should be done. Now, how long should be test be done? Now, there is no hard and fast rule. Remember, it's a very difficult test, so we want to finish it off rather than try to curtail it a bit early. But typically, 6 hours below 6 months, 8 hours between 6 to 24 months, and 12 hours after that. So, adults can take a long time in this sort of a scenario. So, what do? You check the weight, you check the target weight, no, and sodium, plasma osmolality, and urinary osmolality. Check weight hourly, urine output hourly, osmolality at 2 and 4 hours, and serum sodium and plasma osmolality after 2 and 4 hours, then hourly. Stop the test if sodium is more than 146, your diagnosis is made, urinary osmolality more than 600 di is excluded, and weight goes below target. This is the most doubtful indication. So if the child is not sick, he is not having dehydration, I would probably continue a bit more. Often sodium is 144, 145, and there is some dehydration. If you continue for an hour, you will see the sodium to rise. So if you terminate there, then your whole process is lost. You are not reached any particular diagnosis by that point of time. So as we discussed earlier, you expect a normal individual, as you stop water, to the urinary osmolality should go up with no response to AVP. In DI, the levels will not rise, but if you give AVP, they will be increased by more than 50%. In nephrogenic DI, the increase will be less than 50%. Remember, previously people used to say double, that the plasma osmolality should become double. But now we don't use that criteria, because it's well known, as Dr. Alappan was saying, that if you have long-standing polyuria, the medullary concentration gradient is lost. So you have a quote-unquote acquired nephrogenic DI-like picture. So some response is also good enough. In NDI, there should be no response. That is important to differentiate. And then you have partial nephrogenic and partial central DI, similar scenario. Now, most common error is weight is lost, stop the test. Parents are very anxious. The child is drinking, wants to drink. This is a problem. So don't worry. Vasopressin response may be delayed because, as I said, there is a concentration problem. And because central DI is overall much more common, so always give a benefit of doubt. And then treatment of central DI is much more straightforward compared to nephrogenic DI. Central DI, you have a specific treatment. Nephrogenic DI, you are trying to basically decrease the renal function. It's like that extreme treatment. You're using drugs to decrease GFR, to decrease polyuria. So that's not an ideal treatment. But if you have central, you treat. So that is why often we will wait for even a day. So we give a test, check 2 hours, 4 hours, and then ask, okay, what happened to the urine output later on? Some people say that unless you have a genetic diagnosis of NDI, you give a trial of AVP. What will be the harm in giving AVP to somebody who has nephrogenic DI? There's no harm. So the only harm of AVP would be if somebody has psychogenic polydipsia. Then if you give AVP, then they will have a lot of problems. Those people will already concentrate, so they will be gone by that time. So the point is that you give AVP for 2-3 days, and maybe this delayed response comes in. Then it is central rather than nephrogenic. That is important from that regards. Overnight fast should be avoided, particularly with severe polyuria, to avoid dehydration, which may be life-threatening in that regards. Now, very importantly, we have discussed that AVP plays a vital role in regulating the 2% water which is reabsorbed in the collecting duct. Another important process is the medullary concentration gradient. Which mechanisms develop this medullary concentration gradient? That is between
the nephron and the blood vessels surrounding the nephron.
Yes. So loop in Henle and vasa recta. So the descending loop of Henle, basically you will have water will go out, sodium cannot go out. Ascending loop of Henle, sodium will go out, water will not go out. So urine becomes concentrated. Vasa recta is parallel to that. The sodium that is coming out from the ascending loop will go into the descending limb of vata recta. Concentration goes up. So from 300 milliosmoles per kg to 1200 milliosmoles per kg, this is the medullary concentration gradient. If you have long-standing polyuria, you will lose it. So this part is not there, so AVP alone may not be effective. As we say that if somebody is mineralocorticoid deficient and you just give them aldosterone without salt, it is not going to help. Similarly, here this medullary concentration gradient is not there, so AVP is not going to work a lot in that regards. So this area, the urinary concentration becomes important. So long-standing central DI, including primary polydipsia also. So some primary polydipsia may also behave like NDI, that your urinary concentration gradient is not there. So even with AVP, this concentration does not happen because we have got this quote unquote secondary DI and a less AVP response. Now, the other way to go around is to use the measure of AVP. So as we discussed, AVP is very rapidly degraded in the blood. It's not a good marker. We can think of copeptin, and copeptin now is emerging as a marker of the DI status. So if somebody has a level which is high at the baseline, this is nephrogenic, and on stimulation, it should be low, that is central DI. So this is how you identify. So 4-year-old boy with polyuria, Dr. Sandeep, urine output 6 ml per kg per hour, sodium is 140, urinary osmolarity is 70. So,
yes, it is closer and still 140. So, you don't do 6. He is basically having polyuria, sir. And the calculated osmolarity is less than 300 in this case. So we should go for a water deprivation test.
So we should, yes, so you should go for a water deprivation test, advised overnight fast. You agree? He's a smaller, just like this case that we discussed just now. But I would be a bit wary about this urine output. But this case is 15 ml, so I'll be more wary also in our case also. So he developed seizure. So this is something you need to be cautious about, that they develop severe dehydration in that perspective. So this is something to be avoided. Dr. Nimisha, 5-year-old girl with polyuria, urine output is 4 ml per kg per hour, borderline sort of a thing. Sodium is again 139. Everything is normal, calcium, glucose, pH, potassium, everything is normal. Water deprivation test was done. At 6 hours, the urinary osmolarity is 130 and serum sodium is 144. The child has lost 5% weight. And do you want to continue or discontinue? Discontinue. You are on the very edge of getting the sodium above 146. He is not looking very sick. So maybe continue for some more time. So what I'm saying is that this is the least important indicator. If the child is sick, there is shock, then okay. But 5%, 6% doesn't matter. So I think here maybe continuing will be better, because otherwise you will be lost again. You have to do the test again. The other option here could be that, what else could you do? You want to build up the sodium without having dehydration. What can you do else? You give a 3% saline. So saline infusion can also be considered. But generally you wait for 1 hour. The child, so it is an acute phase, now it should rise up. Sodium should rise up. Water deprivation test was continued. At 8 hours, sodium was 148, urinary osmolarity 140. What is the diagnosis? So this is DI. Pitracin was given, 1 unit per meter square. 2-hour value was 200. So what do you think? The increase is less than 50%. So, but there is an increase. So what I'm trying to say is that don't exclude central DI. It's not confirming it, but it's not excluding it also. So in this case, if you had waited for more time, at 4 hours, you see the level is increasing. And often the next day they said, okay, after the injection, the urine output did not increase too much. So this is a secondary NDI, which you have to be cautious about in that regards. Finally, what about the further workup, central versus nephrogenic? You do a vasopressin test. Once your serum sodium is more than 145, osmolarity less than 600, you give AVP 0.1 unit per kg or 1 unit per meter square. DDAVP can also be given, which we don't really use, and measure urinary osmolarity at 2 to 4 hours. If the increase is more than 50%, as we discussed, the central, less than 50% is nephrogenic. Finally, the cause. So as I discussed, early infancy means malformation or genetic cause. Early childhood, genetic, LCH, and of course, infection becomes important. Late childhood, CNS condition, craniopharyngioma, adolescence, glioma become important, along with sarcoidosis and hypophysitis. Look for rash, seborrhea, ear discharge, think of histiocytosis, visual complaints, septo-optic dysplasia, hearing abnormality, diabetes, optic atrophy, DID mode, drugs, lithium, amphotericin B, ifosfamide, micropenis, other malformations, MPHD, and of course, calcifications in the brain, developmental delay, think of nephrogenic DI. Look at neurological features, CNS insults, and infection. Very importantly, skeletal survey in every child to look at lytic lesions. You can do a genetic analysis if required. AVP antibodies not done very often. Bone biopsy for LCH to identify in CSF HCG if there is a thickened pituitary stalk. Neuroimaging is mandatory. So absent posterior pituitary bright spot, does it differentiate central versus nephrogenic? It will be absent in both because it may be exhausted in that regard. So look at posterior pituitary hyperintensity stalk and CSF HCG if there is a stalk thickening. For nephrogenic DI, look for drug history, look at renal imaging, ultrasound, CT, IVP, and if there's mental retardation, get a CT head for calcifications. Central DI, do a MRI if it's normal, follow up MRI 6 monthly for 2 years and then annually after that. Abnormal, of course, think of biopsy, stalk thickening, look at CSF, HCG and skeletal survey. And if it's normal, you follow up from that regard. So stalk thickening is an important pointer to look at. 1 month-old boy with failure to thrive, high serum sodium, urinary osmolality low, given pitocin. So Dr. Alapan, 2 hours urinary osmolality is 300. So this is central DI. So you have to look at other things. So malformations, nystagmus, no blink response. So this is a septo-optic dysplasia. 12-year-old boy, central DI for 2 years, normal MRI and DDAVP was being given. Now develops seizures and headache. Sodium is normal and you find this. So there is a tumor. So this germinoma was missed out. It may develop over follow-up. This is something you have to be cautious in that perspective. So follow-up MRI should have been done every 6 monthly in this child. 3-year-old boy with polyuria, Dr. Nimisha, sodium is 154, urinary osmolality is 180. So this is DI. Now there is rash. There is X-ray skull. What do you expect? Yeah. So you would get these punched out lesions which are there, which are not coming here very well, but there is a lytic lesion which is there, which you will identify.